Dear colleagues, welcome to the Expert to Expert interview on new perspectives in metastatic urothelial carcinoma. I'm more than pleased to be sitting here virtually with my friend Professor Enrique Grande from Spain, a world-known expert in advanced and metastatic bladder cancer, and not only of that, but he's really like the person I would call if I have questions on bladder cancer. Hi, Enrique, how are you?
Hi, Axel, good to see you.
So before preparing this interview, and I'm always a little excited when talking to you because I know you're really up to date. I just asked ChatGPT, how do I treat metastatic bladder cancer? And the answer was platinum-based chemotherapy, maybe some combination, maybe do surgery. So I'm not quite sure if this would really help us in clinic. And I'm happy that I have you as an expert. I think in metastatic urothelial carcinoma, depending on the patient profile, we have like 4 options to start. Maybe you can allude to that on the audience to tell you what's your approach and what options we have now in 2024.
Well, Axel, I think you need to update your subscription to ChatGPT to the new one. So hopefully they will give you more options in the first line. Well, seriously speaking, Axel, I think we have very good news in the field of metastatic urothelial carcinoma because just 3-4 years ago, we have only one choice: chemotherapy, platinum-based chemo. And we were discussing about the traditional Galsky criteria, classic Galsky criteria to classify patients into eligible or ineligible to receive cisplatin. And we were discussing about that for decades. And now, as you mentioned, we have 4 different systemic alternatives to treat our patients in metastatic urothelial carcinoma. Probably the most active one, fashion one, is the combination of enfortumab vedotin and pembrolizumab, the new antibody drug conjugate targeting Nectin-4 that we have. I think the data coming from the pivotal trial, the EV302, demonstrating a superiority versus the old chemotherapy scheme in terms of overall survival, progression-free survival, overall responses. Despite it is not really impacting in the quality of life, as we just saw at ASCO recently. But I think clinically speaking, this is the mostly considered standard of care in this setting. Second option, the triplet, cisplatin, gemcitabine plus nivolumab, the synergism in between the old chemotherapy plus immunotherapy in patients eligible to receive cisplatin according to Galsky criteria. I think there is a subgroup of patients, particularly those with lymph node-only disease, that can potentially benefit from this strategy. We can discuss about if the benefit is really coming because of the synergism when we are giving both strategies, chemo and immunotherapy together, or the benefit in terms of survival is coming from the maintenance part of giving nivolumab after the induction with chemotherapy. We can discuss about that. Third option, that was the former standard of care. That was the standard of care for a very few time, only a couple of years. Induction chemotherapy, 4, 5, 6 cycles of Carbogen, Cisgem, followed by avelumab maintenance for those patients with a clinical benefit during the induction chemotherapy. Javelin bladder strategy, maintenance strategy, has been considered the standard of care for a couple of years. I think it still have a role, particularly for patients that cannot tolerate, or we think the patient will not be able to tolerate enfortumab vedotin, or simply we don't have access to enfortumab vedotin scenario. So probably this is the setting in which the induction chemo followed by avelumab maintenance has a role. And for those patients ineligible for platinum, according to Gupta criteria, those patients ineligible or unavailable to receive enfortumab vedotin, single agent PD-1 or PD-L1 inhibitor, pembrolizumab or atezolizumab, still may have a role. Why not? Don't forget, Axel, and I think this is a challenge that we have in the clinical setting, data coming from the real world in the US are telling us that around half of the patients, despite of the devastating diagnosis of metastatic urothelial carcinoma, are not receiving any systemic treatment. That means that the aggressiveness of the tumor is so high the comorbidities of the patient profile that we visit in daily practice is really damaged because of these comorbidities, and the patients at the end are not really considered for an active systemic treatment. So that's the elephant in the room that we have, and hopefully with this new range of new options that we have, more patients can be can benefit from these strategies.
Well, thanks a lot, Enrique. And this is like a complete picture, and impressive that you can summarize this without slides and understandable even for me as a urologist within like a couple minutes. So excellent. The question is, I mean, we have, let's, in an ideal world, we have all four options available. What guides you? Do we have biomarkers, or would you say like specific, how you say, adverse events, like maybe neuropathy with enfortumab vedotin when you are somebody that playing the violin? Maybe this is something you don't want to have, where others maybe are too frail for combination with IO and platinum would maybe go. And I fully agree what you alluded to, that we should avoid to miss like 40% of the patients not receiving any treatment. I think that's scary. We once in a while have had it too, like very fast progressing patients where we thought we can't start, but I think give it a shot at the beginning. But do you have markers? I know you're an expert and did a lot of research in biomarkers. Can we use markers nowadays in clinic already to guide us?
Axel, I love that question, because I think our work in the hospital, our duty, our task is to try to tailor the different systemic treatments that we have to the patient that we have in front of, clinically speaking, or with biomarkers. Clinically speaking, what are the profilings that we used to consider in the past? Well, we were using the traditional Galsky criteria and Gupta criteria. But these criteria are, in my opinion, a little bit old-fashioned right now because of the availability of enfortumab vedotin. Enfortumab vedotin tolerability is not depending on the traditional Galsky criteria that we were using: audiometry, hearing loss, creatinine clearance. Enfortumab vedotin is metabolized through the liver mostly. ECOG performance status. Okay, ECOG performance status is conditioning for the activity and the tolerability of any systemic treatment that we are offering. So this is not just particularly for enfortumab or for platinum-based chemo. Echocardiogram, so the cardiac function, So the traditional Galsky criteria are really telling us the picture of the patient that we have in front of. I wouldn't select my patients to receive enfortumab vedotin plus pembrolizumab based on Galsky criteria or Gupta criteria. When I have a fellow just seated in my office close to me, I am always telling them, okay, you need to know the guidelines, you need to read the guidelines, you need to understand why the guidelines are suggesting that or that systemic treatment. You need to know the patient profile. You need to know the toxicity profile that you can expect from the different alternatives. But at the end, you need to try to use the common sense. Why I'm saying this is because, okay, you have enfortumab vedotin and pembrolizumab, probably the most potent combo that we may offer to our patients today. Okay, the question, Axel, all patients are good candidates to receive enfortumab vedotin. All patients can afford, in terms of clinical sense, to receive enfortumab vedotin and pembrolizumab. And my response is very easy. Not all patients are eligible for enfortumab vedotin. What about those patients with uncontrolled diabetes? What is the percentage of patients in Germany, in Spain, in any country in the world with undiagnosed diabetes? Particularly when we are talking about metastatic urothelial carcinoma, the typical patient that I have in my mind are men older than 75, 77 years old with comorbidities, hypertension, dyslipidemia, heart attack or cardiovascular alterations, heavy smokers, most of them with alcohol intake. So at the end, the uncontrolled or undiagnosed diabetes is an issue that we may face. I had the opportunity to talk to Alison Birtel, a common friend of ours, and she told me that in the famous Stampede trial in prostate cancer conducted in the UK, one of the inclusion criteria that they needed to amend was the glycosylated hemoglobin. Do you know the percentage of patients that were screened in one of the arms for the stampede? Of course, this is prostate cancer, and I am probably making a bias of comparing prostate cancer profile versus a bladder cancer profile, but the age is not that much difference, so the comorbidities shouldn't be too different here. The percentage of patients who were screening failure at the stampede because of the inclusion criteria of hemoglobin glycosylated above 8, it was 50%. So in the British population, the percentage of patients with uncontrolled or undiagnosed diabetes is around 50%, 50. So that's a challenge that we may face. I am not saying that all patients with uncontrolled or undiagnosed diabetes are not able to tolerate enfortumab vedotin. I'm not saying that. But what I'm saying is that these patients were not recruited in the EV302 and in the EV301 as a single agent enfortumab. So we don't have any data about the safety of enfortumab vedotin in this particular population. What about if you have a patient that is living alone? If you have a patient that is living alone, he needs to take care of himself. I don't know, go to the bathroom, washing, do the shopping, do everything, you know. This kind of patient that is living alone can afford for a neuropathy. You know, quality of life, things surrounding the patient profile are really conditioning in daily practice our different alternatives that we may offer. This is from the clinical side. From the biomarkers, well, I think, Axel, we agree. And despite we did in the past a huge effort to try to see if we have a biomarker related to immunotherapy, PD-L1 expression in the tumors, unfortunately, we don't have a good response. I don't think PD-L1 expression is a reliable biomarker that we should offer, we should use in daily practice. What about biomarkers to antibody drug conjugates, particularly Nectin-4 expression, Nectin-4 amplification of the gene? We know that the expression of Nectin-4 may be evolving in time. In primary tumors, we have a high expression of Nectin-4, but unfortunately, the expression of Nectin-4 is not maintained in the metastasis of some patients. This expression of Nectin-4 is conditioning the activity. Retrospective data from colleagues from your country, from Germany, are telling us that probably the activity of enfortumab vedotin is conditioned by the expression of Nectin-4 in the metastatic tissue. Should we do rebiopsy to our patients? I don't know. Should we try to do functional imaging? There are now new PET scans with tracers that are targeting Nectin-4. So this is a kind of PET PSMA, but for bladder cancer, for the Nectin-4 expression. Should we try to implement these new functional images in the daily practice? Maybe. Unfortunately, we saw the data from the TROPiCS-04, a press release in which sacituzumab govitecan targeting Nectin-4, targeting TROP2, is not positive for overall survival. So let's forget about TROP2, but there is a tumor agnostic indication for trastuzumab deruxtecan for those patients targeting, for those patients overexpressing HER2. Maybe that's another target that we may have with another antibody drug conjugate. I don't know. We need to keep working on trying to identify a good biomarker to select our treatment in daily practice, Axel.
Thanks, Enrique. And so just for the last couple of minutes, I mean, we have erdafitinib in second line. I mean, when we start with a modern combination, it's always like either chemo with IO or ADC, enfortumab vedotin with IO. So the question always comes up then, what's next? Even though we have impressive first-line results, the question is what comes next? We have erdafitinib. We still have in the guidelines, once in some guidelines, paclitaxel. We still have vinflunine available in Europe. So what's your take on second line, which we should offer to patients?
Well, if you have a patient treated with EV-pembro in first line, I think the most used regimen in the second line setting, if the patient is fit enough to receive it, is carbogem. Based on what? Based on nothing. Based on trying to use the common sense. I wouldn't offer for paclitaxel or vinflunine or docetaxel because of the cumulative neurotoxicity. I wouldn't offer that to patients progressing to EV-pembro because of this risk of neurotoxicity. And of course, we have the opportunity to try to try to offer for precision medicine, try to test molecularly our patients for FGFR3 fusions or mutations to go for erdafitinib. The issue, the most important challenge that we have to use the precision medicine is that we need to do the NGS testing in the metastatic tissue. So you need to rebiopsy the patient. You need to wait for the molecular testing, and sometimes when the patient is progressing to EV-pembro, you don't have time to wait. So probably we need to think twice. We need to do the molecular testing as soon as we can, probably during the first-line treatment, just to have the test ready when the tumor progresses to the systemic option that we are offering in first line. I briefly want to give my comment about erdafitinib. Erdafitinib is extremely potent in terms of responses, can overcome the resistance to previous treatment, but the duration of the response is not that long. It's about 6 months only. So this is the major challenge that we have. Toxicity is an issue as well. So we still need to balance the risk-benefit of offering erdafitinib to our patients in daily practice.
Well, thanks a lot. And probably we'll need another 15 minutes or even more to discuss once we have seen the perioperative results of enfortumab vedotin and pembrolizumab, which are coming. But I think we have to reschedule this until we see the final results. Enrique, thanks a lot. Thanks for joining us here in this expert to expert discussion. I had learned a lot again and looking forward to meeting you next conferences. Take care. Thank you.
Always great meeting you, Axel. Thank you so much.